was a significant debate at that meeting, but yet there was the strong inclination to develop guidelines that could serve as some standard of care in the treatment of Lyme. And hopefully that's what will be presented for your consideration.
Everybody's slides working except mine. I checked the carousel at a break and I don't know what happened to it. It's not working. While the young lady's getting that together for me back there, what I'd like to do is I'd like to give credit to the people who were at our consensus meeting. And as Dr. Cleveland mentioned, it was November 17th of last year. I just want to go through the list very quickly. We had about 50 total participants. There were about 50 total participants. 30 people were actually there, scientists and researchers, and about 20 input from all over the country. Very quickly, Dr. Raymond Adelizi, Russell Cancelleri, Patty Cora, Sam Donta, Sandra Evans, Gloria Gaston, James Katzel, Diane Kindry, Robert Lesser, Ed Masters, Alan Barber, Charles Christ, Charlene DeMarco, Paul DeRay, Brian Fallon, Malcolm Gould, David Kazarian, Robert Lane, Ken Ligner, Andrew McBride, Joseph Boroscano, Craig Cleveland, Ingeborg Jezik, Claude Garan, Susan Jacobson, Laverne Kindry, Paul Lavoie, Barbara Martin, James Miller. As you can see, there was people from all over the country, NIH, CDC, so this isn't something that a bunch of people got together with a unifocal focus and said, well, this is what we need to do with Lyme disease. No, it's a broad, generalized view. Susan Miller, Phil Paparone, Bob Quackenbush, who is from NIH, Steve Schutzer, J. Lawton Smith, Dick Tilton, Phil Williams, Jody Tolley, Charles Pavia, Julie Rawlings, Maury Schwartzberg, Bob Spector, Phil Watsky, Charles Weber, Audrey Goldstein, Rudy Scrimenti, Ron Schell, Dorothy Petruca, and Pam Paparone. Nurses, physicians, scientists, and researchers. What I'd like to do is I'd like to give you the guidelines that we came up with. These will be hopefully published. These will be written up and hopefully published so that we, the physicians who treat a little bit more aggressively, will have something to go on. And you, the clinicians, will be able to say, well, yeah, this has been peer-reviewed, and this is something that we would like to put out to you. There are a couple of things that we need to keep in mind when you're choosing an antibiotic. And again, a lot of this is repetition, but I think it needs to be repeated to make the point. The generation time of the bacterium, as Dr. Cleveland very eloquently told us, if tuberculosis' generation time is 12 to 18 hours, and we treat that for 6 to 9 months, why do we treat Borrelia disease, Lyme, Borrelia burgdorferi, for 28 days? It just doesn't make sense. And they also, this is something I'll touch on a little bit later, there's a lot of combination therapy. And now, again, it's not been proven, but it's something that we can think about and perhaps put into some perspective. How the bacteria can evade the immune system, there are various mechanisms for that. The intracellular reasons, where it will get into fibroblasts, where we'll get into macrophages. Antibiotics don't get there. We do have some new antibiotics that we have that have made a difference. Host immune complexes, reconfiguration of the outer cell, of the outer coat to form a new molecular weight layer that the antibiotics may not work with, and also the S layer. That's not on there. Joe just pointed that out to me. As Dr. Bergdorfer mentioned, and I was speaking with him outside, I think one of the most important things that we can do as physicians and clinicians is to emphasize prevention. There's no question that if we can prevent this disease, we're not, as I forget who said it yesterday, but just don't let them bite you. You know, if they don't bite, there's not going to be a problem. What I have told people to do, and patients when I've been speaking literally all over the country, do tick checks. I mean, it sounds weird, it sounds corny, it takes time, think it really would make a difference. I live in an endemic area, and nobody in my family, thank God, has Lyme. But we're very meticulous with tick checks. The other thing that I think people need to do, and I'm not sure this has been published anywhere, is something very practical. When you come inside, especially with children, and even yourself, I was working out in the garden a couple of weeks ago. It was nice and warm. It was 70 degrees outside. Came inside, right in the garage, took all the clothes off. We don't run through the house naked, but you get the point. You take your clothes off, throw them into the dryer. Put them into the dryer. Run the dryer at a high heat for 5 to 10 minutes. If there are any ticks on there, they will be killed. If you take those clothes out and you put them in your hamper, put them in the bathroom, if there are any ticks there, they're going to find a host within your home, whether it be your pets or whether it be yourself. So do that. And I cannot stress that and emphasize that enough. Again, prevention and preventative measures. Treatment after exposure to the disease, reasons for using higher doses of antibiotics. What are some of the reasons? What are some of the practical reasons that we know about? And again, none of this stuff has been made up. This will all be referenced when we write this up. Deep tissue penetration is needed for appropriate treatment. Standard dose X is adequate for some, but not for everybody. And as Joe Berscano always says, it may not be a bad idea. If you look at ampicillin, if you look at any of the antibiotics, if you check levels within the blood, you will see how low some of them really are. So achieving the appropriate dose is important. There are multiple strain variations, and I think that's being studied and being looked at and hopefully will impact on treatment and diagnosis later. The next point is something that Ken Ligner made at, I'm sure you've all seen the videos that have been playing from the Lyme Foundation where Craig Cleveland, Joe Berscano, Ken Ligner, and myself, we made the physician video. And Ken Ligner made a very, very nice point, and from that day I've always remembered this word, the therapeutic alliance. We as physicians have got to develop an alliance with our patients and explain to people that this is what's happening, here's why I'm treating you, and here's my reasoning for being treated. You as the patient have to accept that and be willing to take whatever comes along with that. Okay, so you're going to get a little bit of diarrhea, fine. You need to be confident in what's happening and in what's going on. And develop that alliance, because if we don't, nothing's going to happen. That's the first place, and that's communication. And I think Ken gets the credit for that phrase, therapeutic alliance. Now, what are the risk groups? Antibiotic prophylaxis is recommended for known tick bite. There's no question in my mind that if you're bitten by an Ixodes damini, by a deer tick, you need to be prophylaxed. Why? I think the literature, the data is astounding in our favor to treat people on tick bite. You need to know where you live. Most people know where they live. Geographic risk group. If you live in Hunterdon County, if you live in Morris County, I'm talking about New Jersey, if you live in Ocean County, if you live in New Jersey, period, and you're bitten by an Ixodes damini, I firmly believe that you need to be treated. There's a wonderful article in JAMA by Dr. Datweiler that stated 2 weeks after bite, they did LPs on people in acute disease, and they had Borrelia antibodies by PCR technology in the CSF. And what was frightening was only 50% of those people had any symptoms, and 50% did not. I think that's astounding. I am not willing to take that chance. If I were bitten by an Ixodes damini or a deer tick, you can be darn sure, I didn't say that bad word, which I always say, you can be darn sure that I would treat myself or anybody else that I care about and love. Savings to society. Dr. Vanderhoof has demonstrated this on many occasions and has pointed this out to us. I don't think there's a question about that. The type of tick, as I mentioned, geographic area, duration of attachment. Some people say it's 24 hours, but we know that it's probably a lot less. I believe, and not I believe, but our consensus is that if it's greater than 4 to 6 hours, one needs to be treated. Improper removal techniques. If you've got the guy that's going out hunting and coming in and picking ticks with off with his fingers, you might as well just inject the Borrelia burgdorferi right into the capillary of the vein. It's the same thing. When you squeeze the back of that tick, it's going in. That's it. This next slide is my favorite slide. This is from Dr. Masters. Lyme is a clinical diagnosis until the diagnosis is made. And it's true. And I remember Ed saying that to me, and I've heard him say that at numerous other meetings. You can think about it, but once you make the diagnosis, it's not good enough. The problem is that we as physicians have got to believe our clinical acumen. What that means is you have to have, when you're making the diagnosis, I'll leave that word out. There's no question that we say that this is a clinical diagnosis. And if you look at some of the papers that have been recently published about this disease being overdiagnosed, the gist of that paper is based on clinical serology. Is based on serology. It's not based clinically. There are so many holes in that it's absolutely a sin. We as physicians, we as clinicians, have got to believe our clinical diagnosis. And you know what? We get shot a lot of times for what we believe in. Okay. Diagnostic and therapeutic categories. Early localized, disseminated disease, and we broke that. It's kind of a restaging or a reclassification in order for treatment. It was a little difficult to break out stage 1, stage 2, stage 3, and I think this is again changing and evolving, and you're going to see some of these changes being made. Early localized, disseminated. You've got early localized, then you have disseminated disease, early disseminated disease, late disseminated disease, refractory disease, chronic relapsing or chronic disease. And I'll go through each one, and Ken just went over some of the signs and symptoms. I will also give you some of the treatment guidelines that we came up with. Early localized, single EM rash, no other symptoms, no signs or symptoms of disseminated disease. Treatment. What we're recommending for a single EM rash, no other symptoms, and no other signs or symptoms of disseminated disease, treatment for 30 to 45 days with the following medications that are up here in these doses. Amoxicillin 3 grams a day, probenecid, a combination with a probenecid 1.5 grams a day. Doxycycline 100 milligrams BID, obviously not in children because of the tetracycline compound and pregnancy. Minicin 1.5 milligrams per kilogram and Septin 500 milligrams BID. Some very basic treatment guidelines and the days. 30 to 45 days, 4 to 6 weeks. Disseminated disease. Early disseminated disease, again, just to review the symptoms real quickly. General fever, flu-like symptoms, lymphadenopathy, neurologic, severe headaches, meningitis, aseptic meningitis, cranial neuritis, radiculitis, meningeal radiculitis, spondylitis, or stroke. Again, as Ken said, we're not sure that stroke really fits in there as an early, but anyway. Dermatologic, multiple lesions per bite, lymphocytoma, and again, you can just go through this whole thing. The treatment recommendations that we have for this are a minimum, and I stress, and I cannot stress this enough, a minimum, and I'll circle it, and I'll say it again, a minimum of 6 weeks with an option to extend. This is as far as we are all concerned, this is very important that we keep this in mind. A minimum of 6 weeks with an option to extend. And again, you can see the medications here with the appropriate doses. Amoxicillin 3 grams a day with probenecid 1.5, doxycycline 2 to 4, again not in children in pregnancy. Minicin 200 to 400 milligrams per day, not in children in pregnancy. Zithromax, which is azithromycin, and clarithromycin, they are the new azolides in those doses, again, are just for children. And Septin, about 1,500 milligrams a day. The last line down here says, option to use IV therapy if no response to PO. Again, a very important point that we need to look at. cannot stress this enough. What we're recommending is a minimum of 6 weeks with an option to extend. I don't think any of this is really earth-shattering to anybody at this point. Disseminated disease late. We have the general profound fatigue. Again, you can read all this. This was all reviewed by Ken. The psychiatric manifestations, I think Dr. Fallon, Brian Fallon, has published a paper. I know Ken Ligner and Joe Berscano had contributed to that, and he presented that is important. I have a button in my office that says, "I'm not crazy, I have Lyme disease." And I've given them out to a select group of patients of mine. And it's true. People will come in and they're told that they're nuts. They're absolutely crazy. There's no way that you can have so many symptom complexes at one time. It's just not possible. Yeah, it is possible if you have Lyme disease. Dr. Vanderhoof demonstrated that beautifully. And again, I compliment him on that work that he's done. Multisystemic disease with multiple systems and multiple symptoms involved. No question. Again, you can all read this. This is late disseminated disease. Treatment? A minimum. Again, I stress the word minimum. And we have a big minimum time in here. If I'm not mistaken, I believe this should be 6. Treat with a minimum of 6 to 8 weeks with an option to extend. That option to extend has got to be left to the treating physician. There's no question. There's no question. There's nobody that knows the patient better than, obviously, the family doctor or the person that's been dealing with this person for X number of months or years. Again, the recommendations: cefotaxime, claflin, 6 grams a day, and the best way to do that is 2 grams TID. There seem to be more problems with the 3 grams BID on this dosing. There seem to be more problems with liver function tests, and there seem to be more problems with white blood cell counts dropping. So be careful with that and how that's dosed. I won't even talk about the ceftriaxone or Cefin garbage that went on, but again, be careful on how it's dosed, and again, 2 grams a day. Penicillin G, 20 to 25 million units a day, and ampicillin, should be a slash in here, 4 to 6 grams a day. The problem with ampicillin is that it's not a stable compound, and it has to be infused relatively quickly. And I believe it has to be infused over like a 4-hour period. So it gets a little bit more inconvenient. It's 4 times a day. You have to do what you have to do. As clinicians, you would be absolutely stupid if you didn't see these patients regularly and do follow-up lab work on them. You would just be stupid. So our recommendations are, and I'm sure these are very logical, obvious things that should be done. On oral medications, we recommend that you see the patient and draw blood. Don't give somebody a prescription for 2 months. Don't do that, because you won't see them. You need to draw baseline liver functions. You need to draw baseline white blood cell counts. If their liver functions are slightly abnormal, which could happen in Lyme disease, you need to dose adjust, and you need to be careful on how the medications are dosed, especially the azolides. If you're giving somebody oral medications, we recommend that you draw blood work every month. If it's intravenous medication, draw blood work once a week. You probably don't need to see them every week, but draw the blood work once a week. I see my patients every week when they're on IV therapy. If they miss an appointment, the IV therapy is stopped. It better be a good reason. And there are people in here I know that have missed appointments and they had a good reason. They brought in a note from their doctor and they were excused. Laboratory tests that we recommend: SMA-12, lights, CBC with a differential. You need to know the platelets and all those things in there. And liver function tests. With the 3rd-generation cephalosporins, you're going to have bumps in the liver function tests. You need to know what they are in the white blood cell counts, etc. Okay? We have found that the sedimentation rate is practically useless when we're trying to follow this disease. A lot of people will say that, well, we'll check the ESR, the sedimentation rate. When the sed rate goes down, we'll know that you're getting better. Doesn't work. Most of the time, the sed rate in Lyme disease is normal. All right. What do we do with people who have refractory disease? Obviously, this is the most difficult category, these next two categories that I'll be dealing with. Persistent signs and symptoms that respond to antibiotic therapy. Well, that's okay. That's pretty easy. Antibiotics do have an effect on Lyme disease. This includes improvement of symptoms, sudden flares. The Yerkes-Herxheimer reaction is significant. It is very significant in this disease. We need to pay attention to it. And the mechanism of that is the antibiotics going in, killing the organism releasing the toxin substance that stimulates the complement system that can exacerbate symptoms. Or a patient's condition decline after the antibiotics are withdrawn. You don't have to be a rocket scientist to figure out that if you're doing a mode of therapy on a patient, they get better. You stop the therapy and they get worse. I don't know, maybe my mind is a little simple, but I don't think you need to be a rocket scientist to figure out that what you're doing is most likely appropriate. So keep doing it. So what do we do with these people? Sometimes we need to extend their therapy, longer duration. Sometimes we need to increase the dose. I think Joe's pointed that out very nicely, where you may not achieve adequate levels within the blood. It may not hurt to draw levels. Change the drug. Don't change the drug every week or every time that there's a problem. Develop a course of therapy and pretty much stick to it, unless somebody's just throwing up or having profuse diarrhea. Obviously, you need to stop. But every time somebody has a reaction, we don't recommend that you just change the medication empirically. Stick with it, cut the dose, and just modify and adjust. Change the method of administration. If they're orals and they're not responding, go to IV therapy. Continuous infusion therapies. And another thing that we put a question mark next to is combination therapy. Do I use it? Yes, I do use it. Do we have data on it? No, we don't have data on it. Is it something that works? Yes, I've seen it work. Again, maybe it's my simple mind, but I don't think this is too hard to comprehend, and I don't see the problem with this. I really don't. We use combination therapy in tuberculosis. We use combination therapy sometimes in syphilis. We use combination therapy sometimes in, and now we're using HIV disease. So why not? As long as the patient is followed carefully, monitored, I don't see a problem with it. This antibiotic therapy decreasing the immune system, I don't know where that came from. I really don't. Pay attention to the patient, do the lab work, and follow the patient, and I don't think there's going to be a problem. Supportive therapy is needed, and I'll get into that in the next slide. Some patients have been proved in peer-reviewed medical literature to have persistent infection. The doctor may decide to go longer, and longer-term therapy in order to avoid clinical deterioration. It's basically the gist of what we need to do. Pay attention to the patient. All right, this is a little bit more difficult. Refractory disease, persistent signs and symptoms, not responding to antibiotic therapy. What do we do now? Antibiotics have not affected on signs and symptoms of Lyme disease. This is obviously the most difficult category. People who we really think have Lyme and are not responding. I don't think, and this is a personal comment, I don't think it's unreasonable to reassess the patient to make sure that you're dealing with the right thing. What I like to do is to approach the patient as if they were a new patient again. Reevaluate them, reassess them. And I do believe, and if there's anybody here that was at the consensus, you can give me some input on this if you'd like. I don't think it's unreasonable to reassess these people. Send them out to a consultant. Send them out to somebody and let them come back and let the consultant send you a letter that says nothing's wrong. I absolutely love Craig Cleveland's slide where, God, I can't believe it, there's nothing wrong with me, right? That's the bad news. But that's what it comes out to. You have letters from rheumatologists, neurologists, and infectious disease guy says, there's nothing wrong with the patient, they're just nuts. Fine. sent them to the appropriate people. They think they're nuts. You believe the patient has Lyme disease. I don't think it's unreasonable to treat them and see what happens. Supportive therapy based on symptoms, continuing testing for new Lyme disease tests, urine PCR, PCR technology, subspecialist evaluation, as I said, psychiatric and psychometric evaluation. There's nothing wrong with seeing somebody if you've got some problems, but seeing blind found. You're not nuts. No, we're trying to help get through some of the rough periods. There's nothing wrong with that. Going to a psychiatrist does not make you nuts. It makes you a little healthier. Monitor long-term follow-up, again, lab work, etc. Non-steroidals, the ibuprofens, if you need them, be careful with them. You're going to burn a hole in your stomach, so be careful how you use them. Tricyclics, Plaquenil, if necessary, with the aid of a rheumatologist. I don't believe that internists or people, family practitioners, I don't think it's unreasonable to get somebody like a rheumatologist involved if you're going to start using something like Plaquenil. Consider retreatment if conditions change. Adjunctive therapy to the treatment, physical therapy, and I know Joe's going to talk to us about this a little bit more. The psychiatric social evaluations, as I mentioned, non-steroidal remittive agents. Again, this is just a repetition of other things to do if people don't respond. Tricyclics, immunoglobulins. Again, that was just something we threw out, not been really proven. Synovectomy as a last result, result. It's important that when you're on therapy, you do the things that your physician recommends. Simple things: multivitamins, acidophilus, B-complex, a lot of water, and no booze. No booze. It doesn't work. It doesn't work. So everybody that got wasted last night, that has Lyme, you're going to feel terrible today. You're all going to feel terrible today. You can't do that. In conclusion, I was at a healthcare conference this past weekend, and the doctor's name was Robert McAfee. He's a trustee for the American Medical Association, and he made a wonderful statement. And he just related the disease to caring. He didn't talk about Lyme disease, he talked about medicine in general, but I modified it a little bit to Lyme disease. When it comes to Lyme disease, we the physicians must not only have quality care, but more importantly, we must have quality in caring. Thank you very much.
Okay, we're going to be changing slides. I too have those similar buttons that Derek had mentioned. I'm not crazy, I have Lyme, but I changed mine to I'm not crazy, I treat Lyme. And again, to reinforce the fact about preventive care, let people be aware of things, I gave a talk in Cincinnati about Lyme disease, and a Girl Scout leader stood up and says, well, what do we do with all the Girl Scouts? We go out in the woods and, we're worried about ticks. What do we do? I said, worry about the Boy Scouts. And again, if they peer up, do tick checks, follow the directions that are in the educational videos that the LDF has, you really can't go wrong. Our next speaker is Scott Samuels with Rocky Mountain Lab, who's going to give us a presentation on antibiotic susceptibility and resistance in Lyme. And here he comes.
I have a quick announcement before we get started. Ed Masters has his laser pointer missing, so if there's a good-intentioned speaker out there who has it in their pocket, I think he'd appreciate it getting it back. First, I'd like to thank the meeting organizers, Tom and Karen Forshner and the LDF, for giving me the opportunity to present my research. Second, I would like to acknowledge my collaborators, my postdoctoral advisor, Claude Garin, who's Chief of Laboratory Vectors and Pathogens at the Rocky Mountain Labs, and also my good friend and colleague, Rich Marconi. Third, I'm going to repeat this caveat a few times, but I'd like to start off by saying that although there is hope that a coumarin antibiotic may someday be used to treat Lyme disease, and I hope it is someday, currently they are not clinically useful because they are not effective in humans and animals, and in fact they may be dangerous. In my talk, I will tell you about the coumarin antimicrobial agent, coumarimycin, and its molecular target, DNA gyrase, an essential component of bacteria. I will also talk about DNA supercoiling, the topological state of DNA, which is induced by gyrase. Then I will present our data on the effect of coumarimycin on Borrelia burgdorferi, the bacterium that causes Lyme disease, and finish off with our current results on the isolation and characterization of B. burgdorferi mutants that are resistant to coumarimycin. We believe that basic research on understanding the molecular targets of antimicrobial agents is essential in the development of effective treatments for Lyme disease. Toward that goal, we are studying DNA gyrase, an enzyme that catalyzes supercoiling of DNA and is required for bacterial cell growth. Coumarimycin has been used in these studies in an attempt to understand DNA gyrase, as well as to identify the Achilles heel of Lyme disease and precisely target this weakness. B. burgdorferi is more susceptible than many other bacteria to coumarimycin. Although this antibiotic is not clinically useful for a variety of reasons, we feel that it serves as an excellent model to study the interaction of B. burgdorferi with antimicrobial agents, as well as to study DNA gyrase and the role it may have in cell growth. We have also found naturally occurring coumarimycin-resistant variants of B. burgdorferi. These will allow us to dissect various aspects of bacterial growth and replication, to explore the biochemistry of DNA gyrase, which is the molecular target of coumarimycin, and to develop a model to examine antibiotic resistance in Borrelia, which could lead to the rational design of treatments for Lyme disease. DNA is the genetic material of all organisms. The most prominent structural feature of DNA is the double helix, with one strand wrapped around the other. This configuration has a topological consequence known as supercoiling, which has profound effects on DNA structure and DNA protein interactions. Many DNA molecules are circular. In this case, it readily manifests supercoiling, as you can see. In supercoiling, one of the two strands is over or underwound relative to the other one. In this manner, supercoiling is analogous to the tangling of a phone cord or a garden hose when it becomes annoyingly wrapped around itself. Notice that the supercoiled DNA molecule is more compact than its relaxed form. This supercoiled molecule migrates faster through agarose gels, as I'll point out later. The relaxed and supercoiled forms of DNA are known as topoisomers because they have the same sequence but different topology. The topology is a three-dimensional conformation of the molecule. DNA gyrase belongs to a class of enzymes known as topoisomerases, which catalyze changes in DNA topology. Gyrase is unique among the topoisomerases in that it can convert supercoiled relaxed DNA molecules into supercoiled DNA molecules. In addition, DNA gyrase can also relax supercoiled molecules, it can unknot or knot molecules, and it can decatenate or catenate DNA molecules. DNA gyrase is a tetramer composed of 2 A subunits and 2 B subunits. Each of these subunits is specifically targeted by a group of antimicrobial agents. The B subunit of gyrase is inhibited by coumarin antibiotics, which include coumaromycin and novobiocin. These drugs were first identified in the mid-1950s from species of Streptomyces. Coumaromycin was discovered in the mid-1960s. However, as I mentioned before, the coumarins have not been clinically successful because of poor absorption, serum inactivation, insolubility, and adverse reactions. The quinoline antibiotics act on the A subunit of gyrase, and they include nalidixic acid, oxalinic acid, and also ciprofloxacin, which has enjoyed clinical success, but not with Lyme. Because of our desire to study DNA gyrase in Borrelia burgdorferi and our hope for finding an effective treatment for Lyme disease, we investigated the effect of coumaromycin on Lyme disease. We looked at the growth of the Lyme bacteria cells in culture. We defined the MIC as the amount of antibiotic required to inhibit 90% of the growth. And this was about 0.2 micrograms per mole of coumaromycin. And this is in vitro. This is about 100-fold more susceptible than E. coli, for example. Although coumaromycin is not useful clinically, recent work from the lab of Tony Maxwell in England on the structure of gyrase and the interaction of the coumarin antibiotics should allow for the rational design of these drugs, which will optimize their performance. B. burgdorferi was also susceptible to a coumarin antibiotic, novobiocin. However, it was relatively resistant to the A subunit inhibitors, oxalinic acid, nalidixic acid, and ciprofloxacin. Despite what appears as a low MIC for ciprofloxacin, this is about 100-fold more resistant than E. coli. Therefore, it appears that the B subunit of gyrase is a more sensitive target for antimicrobial agents than the A subunit. We then pursued the biochemical effect of DNA gyrase inhibition by coumaromycin on the circular plasmid supercoiling. This is a two-dimensional gel which is stained by ethidium bromide to detect the DNA. And the DNA is total DNA from Borrelia burgdorferi. In the first dimension, the DNA molecules migrate on the basis of size, with the smallest ones migrating fastest. In addition, circular molecules also migrate fast due to their compact conformation that I demonstrated earlier. In the second dimension, chloroquine is added. This relaxes the DNA molecule and causes the circular DNA molecules and causes them to migrate slower. Linear and relaxed circular molecules are not influenced by chloroquine, and they migrate along a diagonal. However, supercoiled circular molecules become relaxed by chloroquine and migrate off of the diagonal as they're retarded in the electrophoresis. As you can see, there are two circular DNA molecules in this B31 strain, one about 29 kb and one about 26 kb in size. When coumaromycin is added, these molecules became relaxed. And they migrated, in this case, near the top of the gel. I should point out that circular molecules often can be found in three different locations in gels. A supercoiled form, a relaxed or mixed circular form, and then also a linear form if it happens to get nicked in handling. These plasmids are not lost from the bacterium, but rather are relaxed. And we've demonstrated that previously by a variety of criteria. And we've also found that slightly inhibitory doses for growth of clindamycin will relax these molecules within 2 hours of treatment. And that's about 1/5 of the generation time of the bacteria. Because there are very few Bieber-Dorferi mutants derived from selection, we look for spontaneous clindamycin-resistant variants. We found and further characterized 11 mutants from about 10 to the 10th bacterial cells. CRs 8A, 9A through 9E, 10A through 10E all have MICs approximately 100 to 250-fold more resistant than the parental B31 strain. These variants grew only slightly slower than the parental strain, and they were stable for over 30 generations. To further investigate these clindamycin-resistant variants, we examined their protein profile by SDS polyacrylamide gel electrophoresis. 2 of the variants produced proteins that were not found in significant levels in the parental cell. CR9B had approximately 27 kilodalton protein. This we've demonstrated to be surface exposed, although we do not know what it is currently and do not have any function ascribed to it. CR9C overexpressed a protein of approximately 24 kilodaltons, which we have proved to be one of the major surface proteins, OSP-C. The identification of this protein as OSP-C was confirmed by Western blotting using an antibody against OSP-C that was generated and generously provided by Tom Schwann. This was not surprising because, as Claude and I think Tom also mentioned in their talks, Rich Marconi and I have recently mapped the gene encoding OSP-C to the 26 kb circular plasmid. This is another two-dimensional gel with the circular plasmids off of the diagonal. This gel was blotted to nylon membranes, and oligonucleotides directed against the OSP-C gene were used as a probe. As you can see, only one band lights up with this probe, and this corresponds to the 26 kb circular plasmid. To my knowledge, this is the first Borrelia gene found on a circular DNA molecule. This work has also been done recently in the lab of Alan Barber. Bacterial gene expression has previously been shown to be influenced by DNA topology and supercoiling, and therefore the production of OSP-C in this variant CR9C is likely to be a consequence of perturbed supercoiling of the circular plasmids. We thus next examined the topological conformation of the circular plasmids from the clindamycin-resistant variants using a one-dimensional agarose gel. We found that the circular plasmids are no longer maintained in a supercoil conformation in many of these variants. These plasmids are not lost, but rather have migrated so they're relaxed. This is a southern blot in which we've used the 29 kb circular plasmid as a probe. And you can see what I mean by the 3 positions that you can find the supercoiled molecule, the circular molecules in: supercoiled form, one that's become linearized during handling, and also a relaxed form. In conclusion, clindamycin, which targets the B subunit of DNA gyrase, inhibited the growth of Bieber-Dorferi isolate B31 at 0.2 micrograms per mil. Bieber-Dorferi was more susceptible than many other bacteria to this antibiotic, and also to another B subunit inhibitor, novobiocin. However, it was more resistant to the DNA gyrase subunit A inhibitors, oxalinic acid and ciprofloxacin. I must emphasize that unfortunately, coumadin is not a clinically useful antibiotic. However, current work on the structure of gyrase and the action of the coumarin antibiotics may lead to the rational design of drugs for the effective treatment of Lyme disease. B31 contained at least 2 negatively supercoiled circular plasmids, and at a slightly inhibitory dose of coumarin induced the relaxation of these supercoiled molecules. We've isolated 11 spontaneous coumarin-resistant variants from 10 to the 10th bacteria, and these variants are 100 to 250-fold more resistant or less susceptible to coumarin than the parental strain. CR9C upregulated synthesis of the outer surface protein OSPC, which we've recently mapped to 26 kb circular plasmid. Variant CR9B produced an unidentified surface-exposed protein of approximately 27 kilodaltons. The relationship of these proteins to coumarin resistance is unknown, but we think that the overproduction of OSPC is likely to be the result of perturbed supercoiling. In the absence of coumarin, several circular plasmids are found to be supercoiled in the variants CR8A, 9C, and 9E, as found in the parental line, while there are circular plasmids that appear to be relaxed in the others. Before I finish, I'd like to say that I know a lot of people are sick from Lyme disease, and a lot of you out here have patients with Lyme disease. And my heart really goes out to all these patients who are sick. All I can say is right now we're working as hard as we can at Rocky Mountain Labs, and it's my great hope that the research that we're doing will someday lead to an effective treatment for Lyme disease. Thank you very much.